What I was asked to do was to talk about predicting outcomes following total knee replacement. And this is important because total knee replacement and total hip replacement are extremely effective clinically and financially, and they're cost effective, and various studies have shown that they are probably some of the better surgical technologies in the world to improve function in patients. So there is a big move for people to justify the use of total hip and total knee replacement. We've got registry data that shows 10-year revision rates of total knee replacements approaching 6% and uni knee replacements at 16%. There's significant difference in revision rates between developing surgeons and developing centres and registry outcomes. Developers often report significantly better outcomes than independent studies, up to perhaps 11%, or 11 times, sorry. And studies from developers often represent over proportional share of the reported component years within implants, and so therefore have a slightly skewed outcome. So I believe that it's important for us as individuals to predict our outcomes following total knee replacement. And I'm going to talk about it in the reference to three factors: looking at scores with patient-reported outcome scores, looking at the ASA rating score, BMI, and then a little bit about registry results. In the NHS, PROMS data is used exclusively to grade and to report on procedures, and as you can see on this slide here, that total knee and total hip replacement do extremely well when we compare them with Oxford scores and other PROMS-related outcomes. We've reported on the Oxford score within New Zealand, looking at the outcomes of our hip and knee replacements. And I'd just like to refresh your memory on this. We looked at the 6-month score, which Chris alluded to in the previous presentation. And the 6-month score certainly gives us an indication of those patients that are likely to require revision procedures. If we look at the receiver-operator curve, which is a curve, the red curve that you can see there, which gives us an indication of the sensitivity and specificity of the 6-month score, we can see that as it approaches to the top left-hand side, it's telling us it's becoming more reliable. So it's quite a reliable indicator that we can predict our score, our revision rate. So if we look at the ROC curve, we can see that it predicts 93% of those revisions that occurred at 2 years. This is important for us because we can look at our knees and we can look at those that score excellent and good and those that score poor, and we can see that if you score less than 27 on an Oxford score at 6 months, then you have a significantly higher rate of knee revision. This is also true at 5 years, so the 6-month score can reflect what happens at 5 years. So the importance of this is that at 6 months we can get a really good indicator of which knees are not going to survive. So it's true for hips too. So both hips score better than knees, as we know from Oxford scores. Scores are often offer an audit information to our individual surgeons. So you as an individual surgeon can access and look at your own scores and see how you are performing. And they also, as I mentioned, can predict whether you're going to require a revision in the future. And so they can limit the number of patients that you may need to review in your outpatient situation. We looked also at the American Society of Anesthesiologists rating score to predict early outcomes. This is used as a comorbidity score often and quite universally. And we can see that this score has a predictive capacity of looking particularly at total knee joint and looking at mortality rates. So ASA 1 and 2 have a much lower mortality rate than ASA 3 and 4. That's not surprising, of course, but it gives us an indicator of which patients are more likely to perform well following joint replacement. For hip replacement, yes, it also tells us whether they survive better, so whether the revision rate is higher, but it's not so true in knee replacement. So if we look at the mean Oxford scores also, we can also categorise and correlate those to both ASA 1 and 2 and ASA 3 and 4, and we can see that this again is statistically significant. So we get an indication from our early observation and assessment of patients of how they're likely to perform following total knee replacement. So we believe that the ASA is an important predictor of early mortality and certainly a predictor of the functional result, and may also predict early revision procedures. A simple thing to do. What about BMI? Well, we've looked at BMI as well and looked at its results in our own local database. So this is a database of total hip joint, total knee joint and uni knees, as you can see there. And we were able to show that there was no real significant difference between the BMI groups. So when we put the BMIs into the 4 categories that are commonly used for the International Society, we find that the average change in Oxford scores really was not much different across the BMI groups. So although BMI heavy people did start with a lower BMI, they had the same improvement following hip and knee replacements. So our results from this was that despite the significant differences in functional scores across BMI, the absolute gain from pre-op to 12-month score is not significantly different between the groups. And certainly higher BMI start and finish with a lower functional score. This has been reported before, but it's also a good indicator to you of how patients may perform. We've mentioned quite a bit about joint registries, and some presenters have talked about how joint registries can be misused, and that's true. They are a blunt tool. But how can they help you with your clinical practice? They can certainly help us with our clinical practice and can improve our surgical outcomes. This is what we get in New Zealand for each surgeon from our joint registry. We get the results from hip and knees that you have done during your course as a surgeon, and also we get our component, the revision rate for hip and knee replacements, and we can compare those to the national average and to see how we're performing nationally. Joint registries also, if they have PROMS data, can tell you how you're performing over the year compared to the national mean. They can tell you how your knee primary surgery rate also compares to the mean. So that's a good information, a good feedback to surgeons to be able to see how you comparatively compare with the rest of the country. The other thing that joint registries can do as well is can look at surgeon outliers. And this is what we do with our joint registry, is we can identify surgeons that are performing 2 standard deviations outside of the normal. So I've presented to you 4 ways of which we can assess